So, hello friends. So, I'll be giving a overview on this airway management in acutely poisoned patients in the ED. So, thanks for having me to deliver this talk for AIMS Rishikesh. So, it's a important topic for everyone to have a little clarity on the key nuances that we need to pay attention to when we are intubating. So when we look at the poisoning in ED, so we could possibly broadly divide them into pharmaceutical sort of a toxicity or poisoning and non-pharmaceutical. When we talk about pharmaceutical, obviously, there's a lot of other drugs. It can be beta blockers, calcium channel blockers, or sedative hypnotics, so on and so forth. But the non-pharmaceutical, you could divide into chemicals, you could divide into solvents, gases and vapors, natural toxins, and food poisoning. Under the chemicals, there are household chemicals like sort of a detergents that you would be using, which can be alkali or acid based, or it can be industrial sort of a chemicals. So this is the sort of a broad classification as to the type of poisonings that we could see. And that is about the structural sort of a variance or the from the properties point of view, the variants of poisoning that can happen. But with regards to intensity, there can be acute and chronic. Acute typically happens as a single short-term exposure, and chronic is a long-term exposure. And more so, this chronic would be more of occupational. So this is how one could possibly approach the type of poisonings that we deal with. So whenever there is a patient in emergency with a poisoning of any nature, there are key elements. There are about 5 elements that we need to see. Whether there is an obtundation with a lack of respiratory drive. So that's the first one. So whether there is a lack of respiratory drive, because this would indicate to you whether this patient needs to have airway protection. So our whole emphasis is on airway, breathing and circulation. More so in poisoning, it is more to do with the airway, whether we need to protect the airway because the respiratory drive is low. That's the first thing. The second thing one would see is whether patient is oxygenating and ventilating and whether there is presence or absence of reflexes, airway reflexes. So if there is absence of airway reflexes, it means there is a higher risk of someone aspirating and one has to protect the airway. So the first one is lack of respiratory drive. Second one is to look at the absence of reflexes. And the third one, which I already said, is you would look at ventilation, whether patient is breathing adequately, whether he or she is oxygenating adequately. So that's the third thing. The fourth thing we look at is whether there is some respiratory compromise with bronchospasm or with aspiration leading to ALI, ARDS, hypoxemia due to the problems within the lungs. So bronchospasm can happen in patients typically with OP poisonings where there is bronchoria and bronchospasm. So that's a fourth thing that we would look at. Fifth thing is we would look at whether there is ongoing neuromuscular weakness due to any poisoning. And there are various poisons which can do this. And the typical one we tend to see often is the OP poison, which can lead to neuro. So these are the 5 elements that one needs to look at in ED to determine whether definitive airway management is needed. And most importantly, one has to bear in mind whether there is an anticipated clinical deterioration that you are foreseeing. And if any of these chemical or any of these poisoning has a potential to cause recurrent seizures, or whether this poisoning has a potential to cause ongoing neuromuscular weakness or respiratory depression. So these are the elements which would indicate to you that there is a possible or anticipated deterioration which needs definitive airway management. And respiratory depression, especially if someone is consumed opioids, sedation, analgesia, or OP, there is a anticipated sort of a trajectory that there can be ongoing deterioration with the consumption that has happened, and one would need a definitive airway. So the simplest quick way is to remember these 5 elements: lack of respiratory drive, whether there's lack of airway reflexes, ventilation is a problem, or whether there is parenchymal lung problem due to aspirations, bronchospasm, crackles, ARDS, so on and so forth, and the neuromuscular weakness. So when we talk about indications for definitive airway, there are two broad entities we look at: whether there is a respiratory failure, or second thing is whether there is a severe central nervous system depression or neurological depression or obstruction that has happened, and patient is unable to protect the airway. When we talk about respiratory failure, we look at whether there is failure of ventilation because of whatever reasons, obstructive airway or neuromuscular weakness, or whether there's failure of oxygenation. So failure of ventilation typically happens when there is a respiratory muscle spasm or when there is a neurological obtundation that happens. Failure of oxygenation typically happens when there is parenchymal issue. So it could be atelectasis, it could be pulmonary edema, it could be pneumonitis, or it could be ARDS. So these are some of the key parenchymal problems in poisoning that can lead to failure of oxygenation. And when it comes to the depression, so this can lead to, there can be airway damage and there can be aspiration, there can be absence of airway reflexes. So these are some of the reasons why one has to intubate. So this is just a broad categorization as to the possible problems that happens in poisoning, which necessitates the need for intubation. And one, of course, has to look for other signs of poisoning when there is a neuromuscular obtundation or weakness, like whether there is ongoing cholinergic symptoms, which is typically slur, blurring of vision, whether there is a excessive salivation, bradycardia, bronchoria, hypotension, diarrhea. So these slug symptoms in concomitantly has to be looked at to determine the nature of poisoning and suitable actions to be taken. So let's talk. So now you have decided that the airway needs to be protected. So obviously, airway, you have to do the jaw thrust and head tilt to open up the airway. And whether one has to look for gag reflex or cough reflex to determine that airway protection is needed. So this has been abandoned. So one need not go on to check whether patient has a gag reflex to determine whether someone needs a definitive airway. And even cricoid pressure is cited to be controversial at this point of time, and there is no consensus whether this would help during definitive airway management. Is GCS the indicator to determine whether someone needs intubation? So we don't have definitive answers. So the most important aspect or the criteria for someone to be intubated, a definitive airway to be obtained, is to look at the clinical gestalt, which means an anticipated clinical progression, clinical trends, and anticipated course. I think these are the three elements which should help you to navigate and determine whether someone needs intubation. If someone needs intubation, early intubation is what is recommended because it is shown to reduce the risk of complications and most importantly, reduce the risk of aspiration. So, in poisoning, one could anticipate peri-intubation complications because of the nature of the poison, which affects multiple other systems and can cause hemodynamic compromise. So, some of the poisonings can cause severe acidosis, and like OP poisoning itself can cause severe acidosis, and there can be hypovolemia, and there can be reduced in the preload, which means when you're intubating, there can be a lot of hemodynamic compromise. So you have to take care of correcting these before you go on and intubate. And there can be increased risk of laryngeal injury and aspiration when you're dealing with certain inhalational poisoning. So one has to correct the preload with fluid boluses and sodium bicarbonate to correct acidosis, especially in cases like calcium tricyclic antidepressant overdose. So they are at a risk for arrhythmia. So one needs to take care of correcting alkalinizing with sodium bicarbonate to ensure that there is no severe arrhythmias or hemodynamic decompensation that happens during intubation. So these are some of the complications related to poisons one needs to bear in mind before embarking on definitive airway. So let's talk about corrosive ingestion. So when someone is taken a corrosive, be it alkali or acid, there are two phases. One is an acute presentation where there is acute inflammation of the airway, of the GI tract, and of the oral cavity. And there are late presentations like stricture, stenosis of the esophagus or of the airway. So late complications, which is dreaded, is the airway stricture or stenosis that can happen. And in corrosive ingestion, nasotracheal intubation is to be avoided, and normal orotracheal intubation is what has been recommended. And even there is a uh, there is a dissuading of using LMA also in corrosive ingestion, and it is suggested the use of bougie and stillets also to be avoided in corrosive ingestion. And if orotracheal intubation fails, so one has to resort to surgical means and always call for ENT help in corrosive ingestion because there can be a lot of airway edema and not always airway may be easy. So orotracheal intubation is the way to go. And because of airway edema, glottis edema, and the uvula and all that which may be inflamed and swollen, supraglottic airway, use of stillet and bougie to be avoided. And if surgical tracheostomy or anterior airway sort of procedure is embarked upon, always seek for ENT. And in corrosive ingestion, always be vigilant and have plan A and plan B before intubation. And these are the patients where hypoxemia and hypercapnia can manifest very early on. They can go to stridor and they can increase risk of complications. So the early manifestations of corrosive ingestions are laryngeal injury, laryngeal edema, and there are risk of aspiration. Late is they can have vocal cord paralysis. There can be scarring of the larynx or the trachea, and there can be subglottic granuloma and adhesions that can form. All this can lead to airway challenges and difficulty in airway as a late manifestation in corrosive. So that's about corrosive. So we'll just move to the type of medications that you would pick while handling the airway in poisoning. So the type of sedative agents and paralyzing agents will determine the ease of intubations and decreasing the complication risk. So when we look at the choice of sedative agents, so one we would have benzodiazepine, opioid, propofol, and barbiturate, and all this is dependent on the type of underlying poisoning. If someone is already taken benzodiazepine, you wouldn't want to give benzodiazepine. If already someone is taken opioid, obviously you wouldn't want to administer opioid, so on and so forth. So management of underlying condition, if patient is agitated, you would have to choose between more of opioid with benzodiazepines, and the choice of sedation depends on whether patient is agitated. If patient is very hypotensive, obviously would avoid using propofol. And so your management and the choice of these drugs depends on whether patient is agitated, whether there is a sympathomimetic overdrive, or whether there is status epilepticus. So your choice of sedation would be dependent on this. And ketamine is something that could be considered when someone wishes to maintain the airway reflexes, and whether one would want the patient to have some sort of a respiratory drive. Ketamine is something that one could consider. So basically, I wouldn't dwell into exactly what drug you would pick up. That is to be determined by the physician who is dealing with that patient based on the clinical context and the underlying sort of a situation that he or she may be dealing with. And when you talk about paralytic agents, the suggestion is neuromuscular blockers improve the intubation condition and improves the success rate. And neuromuscular blocker should be considered in all sort of intubations in sort of toxicity. When there is hypertonicity because of serotonin toxicity or sympathomimetic drugs or hyperthermia or status epilepticus, so one has to use muscle relaxants, which will increase the success and ease of intubation. Rapid onset, short acting muscle relaxants is to be used. So non-depolarizing drugs like succinylcholine can be used. If there is hyperkalemia, then one has to avoid using succinylcholine. So these are the general principles of the choice of sedatives and paralytics that one should consider whilst intubating. So we'll just talk about the procedure of intubation. So there are four types of inductions that happens. One is the traditional, where you pre-oxygenate the patient, give sedation, and then paralysis and intubate. The commonest ones that we tend to use in poisoning is rapid sequence, where we pre-oxygenate and give sedation and paralysis together, and then go ahead and intubate. If there is a failure to oxygenate and patient is agitated, one could use ketamine as a sedative, oxygenate, and then have awake intubation or rapid sequence induction. If someone is not able to ventilate and you're anticipating difficult airway, then one has to do awake intubation by instilling local anesthetic at the airway, and then sedation and intubation without a muscle relaxation. So these are some of the different sequences. And before intubation, always assess possible difficulty of intubation by looking at the mandible, whether there is retrognathia, whether the patient is obese, whether there is limited neck mobility, whether there is history of sleep apnea, and Mallampatti, most of you are familiar with. The simplest way is to look at rule of three, whether you are able to insinuate three fingers between two incisors, or you could look at whether you could insinuate two fingers from the thyroid to the floor of the mouth, or 3 fingers from the hyoid mental distance is what you could look at to determine whether the intubation is going to be easy or not. And Mallampeti, most of you would know class 1 to class 4. If someone has class 3 to class 3 is where facial pillars are not seen and uvula is not seen, only soft and hard palate. And class 4 is only hard palate is seen. That would indicate to you that you possibly would have difficult intubation. So the most accepted grading for intubation is Makocha score. Makocha score has Mallampati. If someone has 3 or 4, you get 5 points. OSA gets 2 points. Limited neck mobility gets 1 point, and mouth opening less than 3 centimeter get 1 point. So Makocha score we divide basically either it's less than 3 or more than 3. If it is more than 3, you could possibly anticipate some difficulty in intubation, and it's better to have some help. And based on pathology, coma gets 1 point, severe hypoxemia less than 80% gets 1 point, and intubation by non-anesthesiologist get 1 point. So if it is more than 3, you have to be guarded and have the difficult gear before you embark on intubation. Total score is around 12. So what are the current challenges? So positioning of the patient is terribly important in emergency. In hurry, don't embark on intubation without neck flexion and head extension. Always keep a pillow below the head or a head ring so that there is a neck is flexed and head is extended. And sniffing, it should be ideally in the sniffing position. If someone is very obese, you can use the ramped up position of this nature. So the steps of rapid sequence intubation in ER is make sure that patient is connected to the monitor, standard monitor, which has ECG, pulse oximetry, and has an IV axis. And many of the poisoning patients could be involved in some sort of a trauma. So cervical spine immobilization has to be considered if you're suspecting trauma. Pre-oxygenate with 100%. And the choice of sedation is always sedation with analgesia. Use fentanyl 1 to 3 micrograms per kg with midazolam 0.1 to 0.33 milligram per kg. After which you can give succinylcholine 1 to 1.5 mg. If hyperkalemia is there, or you wish to use depolarizing agent, so one could think of rocuronium or vecuronium in the doses that is mentioned, 0.6 to 1.2 of rocuronium and vecuronium 0.1 mg per kg, and intubate. Cricoid pressure, there are studies which shows either way, there is no major difference, but you could apply cricoid pressure. But in poisoning, cricoid pressure is to be avoided. And post intubation, make sure you do the auscultation over the chest to look at the air entry. And most importantly, whilst you are taking care of the airway, concurrently one has to see whether there are certain agents that could be put in place the to reverse the poisoning, or the antidote to reverse the poisoning, so that you could avoid intubation. So some of the commoner poisonings that we see, and the antidotes is for opioids, you have naloxone; for acetaminophen, you have NAC; OP poisonings, atropine, pepam; benzodiazepine, flumazenil. If someone has taken ethylene glycol, fomepizole, methanol, ethanol is the antidote; cyanide, hydroxycobalamin, beta blockers, and calcium. You could use glucagon and calcium gluconate. We've had a methemoglobinemia patient where methylene blue is the antidote. Carbon monoxide, you have to, they can be obtended. So you have to oxygenate them at 100% oxygen. If you have HPOT facility, you could subject them to HPOT. Lead poisoning, dimercaprol. And if hypoglycemia is something we see commonly due to insulin or sulfonylurea, dextrose and octreotide. So these are some of the antidotes which you have to keep in mind whilst you are taking care of the airway, so that if intubation can be avoided by reversing the toxicity by using antidote effectively, is another clinical acumen that one needs to exercise. So when you look at the airway algorithm in emergency or ICU, so one needs to have all the gear in place, laryngoscope, ET tubes, stillets, bougies, Giddels airway, and always have 2 operators whilst intubating, and RSI is mandatory. Assess for difficult of intubation and see if Makocha is less than 3, which means it's an easy intubation, go ahead and intubate. In the current recommendations suggest that video laryngoscopy is a better way to intubate. If Makocha is more than 3, the recommendation is to go for video laryngoscopy. So the time has come that most departments, either emergency or ICU, should sort of invest in having video laryngoscopy. That is the sort of recommendation. If intubation is failed, so do mask ventilation. And the second time you try to intubate, it is recommended that have bougie stillets in place and intubate with a video laryngoscope. If that fails, as a desperate measures, you may have to consider LMA, or awake intubation with bronchoscopy. If these fail, then you have to think of surgical cryptothyroidectomy. So that's about the intubation algorithm that is largely accepted in emergency and in intensive care. So summary, in any poisoning, anticipate difficult airway, evaluate for difficult airway and have backup plan, and concurrently treat the poisoning with the available antidotes that one would have determined, and always call for help whilst maintaining or managing the airway in these poisoning patients, and always anticipate there are huge challenges with hemodynamic instability that might happen, or airway compromise that can happen secondary to corrosive poisoning. And clinical circumstances should guide your management of airway, and your clinical circumstances should determine the choice of antidote, choice of sedation, and choice of neuromuscular blocker. So thank you, friends. So request you all to submit your valuable work to Journal of Acute Care. You can visit my website, www.drpradeeprangappa to rehear to this lecture. Thank you. Thank you, one and all.